Hey guys, this is Dr. Joel. Thanks for tuning in to this lecture on the adrenergic receptors. Below is a list or an overview of what I'm going to be talking about in this lecture. You can click on any one of these links to skip instantly to that part. This is a high yield topic, and at the end I do provide you some practice questions just to help prepare your mind for the boards. Okay, let's get started. Alright, the adrenergic receptors, also known as adrenoceptors, are a group of G protein coupled receptors in the sympathetic nervous system. Now, it's important to know about G protein coupled receptors and how each one of them works. However, I'm not covering that in this lecture, so you'll have to look for that lecture specifically. The sympathetic nervous system, however, is also a good thing to think about or keep in mind when you're first learning the adrenergic receptors. And the reason is that if you think about what a target organ does during the fight or flight response or the sympathetic response, you can work through what these receptors do. So if I were to say that one of these receptors was found in the heart and it was stimulated, well, you can think through and logically reason that the sympathetic response, or the fight or flight response, as they say, in the heart is for the heart to beat harder and faster. And that applies for most target organs. So basically, just think to yourself, what is a target organ going to do when I'm being chased by a lion? And you've got it, okay? The picture on the right here is a crude representation of the sympathetic nervous system. The top nerve, the green nerve, is the preganglionic nerve. The middle nerve is the postganglionic nerve, and the larger blue area on the bottom is the target organ, or the organ that the sympathetic nervous system is trying to stimulate. The preganglionic nerve, or the nerve on top in this picture, originates from the spinal cord. The synapse in the middle represents one of the paravertebral ganglia. These synapses use cholinergic receptors, which is, again, outside of the scope of this lecture. So you'll have to look for that lecture specifically. What we are interested in for this lecture is where the postganglionic nerve contacts the target organ. This is where the magic happens. This is where the adrenergic receptors are. The normal physiology for a nerve impulse is that it travels down this presynaptic nerve until it gets to the end here. And through a series of cellular processes, which I will cover in a separate lecture, but I don't have time for in this lecture, it causes these vesicles filled with neurotransmitters to fuse with the membrane and spill out their contents. In this example, the neurotransmitter I've chosen is norepinephrine, which is a catecholamine. But other catecholamines work on these receptors as well, and other drugs, and that's why this lecture is important. We're going to talk about all those so that we understand it. You can see from this picture here as well that there's two main categories that I'm going to speak on, the alphas and the betas. And then I'm going to break those down into alpha 1 and alpha 2, beta 1 and beta 2. Now there are more adrenoceptors than these four, but these I feel are the most important. So if you can nail these down early on, it's easy to add on extras as we go. Okay? So let's move on. Alright, now just as an overview for these four important receptors. This is how I remember these receptors early on. Now, you have to remember that each receptor does more than just one thing, but when you're first learning it, it helped me anyway to clump them together. So, starting with the alpha receptors. For the alpha 1, I think of it as a constrictor, or a vasoconstrictor, okay? And I remember that in my mind pictorially by thinking of the 1 as a vessel and the alpha symbol as a surgeon's tie. So you can see that as the surgeon pulls on the two sides of the tie, it constricts down on the vessel. For the alpha 2s, remember the alpha 2 receptor was presynaptic, meaning that it was on the same side that the signal originated from. It deals with feedback. It's a feedback mechanism. It keeps the presynaptic nerve from running away with the reaction and just it helps contain the reaction, I guess is what I'm saying. So I think of the 2 as kind of an arrow doubling back on the presynaptic side. And I just kind of draw it out like this picture here. All right, now on to the beta receptors. So beta 1 receptors and beta 2 receptors do many things, but I clumped them together. So it helped me early on at least. And then I added more and more as I learned more and more. Beta 1, one heart. Beta 2, two lungs. So why did I do that initially? Well, because there are, in fact, a lot of beta 1 receptors in the heart, and a lot of important medicines that you learn, at least in the beginning, that are usually beta blockers, they decrease sympathetic tone in the heart. So they decrease the speed and the strength with which the heart beats. Beta 2 receptors, the famous one that you'll learn right away, or that everyone kind of knows even before school, is asthma or asthmatics. Asthmatics, when their bronchioles close down, they take a beta 2 inhaler in the form of albuterol to open up the bronchioles again so that they can breathe. So beta 1, one heart, beta 2, two lungs, and we'll add more onto it as we go. Now for a little bit more detail on the alpha 1 receptor. The alpha 1 receptor is postsynaptic. It is most sensitive to norepi and then epi, and much less so to isoproterenol. And that makes sense because isoproterenol is actually a beta agonist. Now, why is this bullet point important at all? Well, it's important because when you start working through the physiology of what drugs do and how things react in the body, you have to know what a receptor is most sensitive to, and then you also have to think through where are the receptors located. Okay? Also, historically, these catecholamines, norepi, epi, and isoproterenol, are important because when the adrenergic receptors were first classified by a pharmacologist, these are some of the drugs he used to help differentiate between the different receptors. So it also has an interesting historical point. Next, alpha 1 receptors have a high affinity for phenylephrine. What is phenylephrine? Well, it's an alpha 1 agonist. Okay? So what might that do on the body? How about this? I currently, as I'm recording this, have a little bit of a stuffy nose. How could phenylephrine help me? Well, it would help by constricting the vessels in my nasal mucosa, and that would decrease the edema and the congestion, and also decrease the production of mucus or rhinorrhea. So just understanding the receptors, you understand how to treat and what things do. Alpha 1 receptors are GQ protein coupled receptors. What does that mean? Well, I'm going to cover those receptors in more detail in a separate lecture, but let me give you an overview real quick. Basically what's happening is when the G protein is activated, it activates phospholipase C. Phospholipase C cleaves phospholipids that are around in the area, many of them from the membrane itself. This creates PIP2, phosphatidyllinositol 4,5-bisphosphonate. It's a big word. Most people just call it PIP2 or PIP2. That is further cut or cleaved into inositol, triphosphate, and diacylglycerol. Then the IP3 goes through the cell and acts on calcium channels and releases calcium into the cell, which we know calcium ions are often used in intracellular processes. Okay, so that's how that receptor works. What do you think of when you think of the action of alpha 1? I've mentioned it already in the previous slide, but basically I want you to think vasoconstriction, or just constriction of smooth muscle. So what happens if we constrict the peripheral vessels? Well, that would increase the peripheral vascular resistance and thus increase the blood pressure. What about the smooth muscles in the eye? The iris dilator muscle. It would dilate the eye. It would cause mydriasis. And also some urinary retention if the receptors in the urinary tract are stimulated. Now on to alpha 2 receptors. These are the presynaptic receptors. Okay? And you can see why in this animation, or what it does. Basically, it, as I mentioned in 2 slides ago, it acts as a negative feedback mechanism to keep the process regulated. All right? Alpha-2 receptors are very sensitive to epinephrine and norepi, and again, more so than to the beta agonist isoproterenol. The alpha-2 receptors have a high affinity for clonidine. Clonidine is what's called a central acting alpha-2 agonist. What do you think it does? Well, I've used this drug a couple of times. It works great, actually, for people who have very high blood pressure. They come in maybe in a hypertensive urgency or emergency. Clonidine will lower their blood pressure pretty quickly, actually. It works by, I think of it as tricking the sympathetic nervous system into thinking that it's getting a lot of feedback. So it decreases the tone of the sympathetic nervous system by just decreasing the amount of release of norepinephrine from the presynaptic side of all those nerves. It is a GI protein coupled receptor. So basically, when the GI protein is activated, it inhibits adenylate cyclase, which thus decreases the production of cyclic AMP from ATP, and thereby decreasing the activity of cyclic AMP-dependent protein kinase. So what does it do on the body? You won't be far off if you just remember inhibition or feedback. Okay? So it inhibits the release of norepinephrine by this negative feedback system that we can see on the right. It also inhibits the release of insulin from pancreatic beta cells where there is actually a higher population of these alpha-2 receptors. And it also inhibits the release of acetylcholine in the parasympathetic nervous system. So very interesting. Let's move on. For our review on the alpha receptors, first off is alpha-1. Remember, it is postsynaptic. There's only one presynaptic that we've talked about, and that's alpha-2. Alpha-1s are very sensitive to norepinephrine. Compare that to alpha-2, where epinephrine is greater than or at least equal to norepinephrine in its ability to stimulate alpha-2s. And both are not very sensitive to beta agonists, such as isoproterenol. Alpha-1s, high affinity for phenylephrine. They are GQ coupled. Alpha-2s, high affinity for clonidine, and they're GI coupled. Now these few bullet points are pretty high yield, so try and remember these. Alright, let's move into the betas. First off, beta-1. Beta-1 receptors are postsynaptic. They are very sensitive to isoproterenol. Okay, the underdog has now become the champion. More so to isoproterenol than to epinephrine and norepinephrine. Beta-1 receptors are GS protein coupled, and you'll remember that this is opposite of GI. So it increases the activity of adenylate cyclase, thus increasing the production of cyclic AMP and increasing the activation of cyclic AMP dependent protein kinase. What are the effects? Well, remember, one heart, beta-1, and then other things as well. All right. So first off, we increase the chronotropy, inotropy, and dromotropy of the heart. What does that mean? Chromatropy is the speed with which the heart beats. Inotropy is the force with which the heart beats, and dromotropy is the speed of conduction through the heart. Beta-1 receptors also increase renin release and lipolysis, and you can see how all three of those points make sense in a sympathetic response. Beta-2 receptors are also postsynaptic. They are, again, very sensitive to isoproterenol, and less so to the other catecholamines listed there. They are also GS coupled, so that's easy, right? Both beta receptors that we've talked about are GS coupled. That helps us remember things, right? When we can clump things together. So what are the effects? So bronchodilation is the first one that I remembered at least, and that's why I clumped it with the lungs, is because the asthmatic that comes in is having a difficult time breathing, turning blue. They take a puff on albuterol, and they're better. What else does beta-2 do? Well, beta-2 receptors are vasodilators. They dilate vessels in the heart and the skeletal muscle, which helps us when we're running from a lion. They thereby decrease the peripheral vascular resistance. And there's even some of these receptors in the uterus, so they can relax the uterus. Now on to the review. So beta 1, postsynaptic, beta 2, postsynaptic. They are both very sensitive to the non-selective beta agonist, isoproterenol, and they're both GS coupled. That helped me remember it, at least. So what are the effects? Well, beta 1 increases the speed and strength of the heart, increases renin release. Beta 2 dilates things such as vessels and the bronchi, and also relaxes smooth muscle. Okay? Good. Well, that was a fast lecture, wasn't it? We're on to the knowledge challenge already. We'll walk you through real slow. Don't worry, you'll do fine. This is the first case. A 59-year-old male presents to your clinic. He's complaining of having a difficult time initiating his urine stream. He just can't pee, the poor guy. When he's finally able to start his urine stream, he only dribbles into the toilet. You, being the awesome practitioner that you are, recognize this as a case of benign prostatic hyperplasia, which is relatively common in older gentlemen, and you offer him a prescription of what? How about tamsulosin? Why? Why would you give him an alpha-1 receptor antagonist or blocker? What you're trying to do is to relax the urinary tract, and this guy has a problem with that because he's got some hyperplasia going on in that area. So if you can relax that area as much as possible, you can help the urine move through. Now, tamsulosin isn't just an alpha-1 receptor antagonist. It's actually a little bit more specific. It's an alpha-1A receptor antagonist. I told you there was more than just those four. There's actually like a beta-3. There's multiple subgroups of the alphas. But just for this basic lecture, it's enough to know that an alpha-1 receptor is going to help this gentleman pee. What if you gave him clonidine? What would happen? Well, he would have a decrease in his blood pressure and probably still wouldn't be able to pee. He wouldn't be happy with you, okay? He'd start looking for another provider at this point. What about epinephrine? What would epinephrine do? That would actually make it harder for him to pee. You don't often pee when you're running from a lion. It would stimulate the alpha-1 receptor and thus tighten everything down in that area. He wouldn't be happy with it at all. He'd get sweaty and his heart would start racing and he'd feel fidgety and agitated. He would definitely go and find another practitioner at that point. What about albuterol? Albuterol usually delivered via inhalation or aerosol. That wouldn't help him. It would maybe dilate his bronchioles a little bit, but he wouldn't be able to pee any better. Okay? So if you pick tamsulosin, good job. Okay, next up is a 48-year-old male. He presents to the ER with rigors, hypotension, malaise, and confusion. All around, he's just not feeling good at all. He's found to be septic on his labs, and he's admitted to the ICU. Soon after arriving in his room, you start to notice that his blood pressure is falling rapidly, and his mental status is getting worse. He's crashing on you. Which of the following drugs could be used to treat his condition in the short term, out of the choices below? So how about norepinephrine? Why? Well, norepinephrine would do a great job at increasing this person's blood pressure because it's a non-selective alpha and a beta-1 selective agonist. It stimulates all three of those receptors. So it's going to clamp down on the peripheral vasculature through alpha-1 mechanism. What about the alpha-2? Well, alpha-2 seems to be contradictory, doesn't it? And technically it is, but it's overpowered by the alpha-1 and the beta-1, because what's beta-1 going to do? Beta-1 is going to increase the chronotropy, inotropy, and dromotropy of the heart. So the heart's going to beat harder, and you're going to have the peripheral vasculature clamp down. Okay, so all in all, you're going to get a pressor effect out of norepinephrine. What about tamsulosin? Well, tamsulosin is the wrong thing to do because it's going to actually, because it's an alpha-1 antagonist, it's going to try and release things or dilate things. And that's what you're trying to get away from, okay? Clonidine next. Well, clonidine is going to decrease the blood pressure. Lastly, albuterol. Nope, Nope, not really going to help someone who's crashing with hypertension from sepsis. So if you pick Norepinephrine, good job. All right, the last question. You are managing a 49-year-old male patient who is recovering from an appendectomy on the general medicine wards of your community hospital. Your medical assistant comes to you and reports that this patient's blood pressure is 180 over 110. You decide, correctly, this is what you're supposed to do, you decided to go examine this person for yourself just to make sure. And other than a little post-surgical pain, he feels fine. He's eating, he's drinking, watching TV. You repeat the blood pressure and you find that, you know what, it is a correct number. It is still about 180 over 110. And your assistant turns to you and says, hey, what medicine should we give him? What should we do? What do you choose? Well, clonidine, if it was there, would be a good choice. But there's another correct answer there. How about metoprolol? Metoprolol is a beta-1 receptor antagonist or blocker. And remember, beta-1, one heart. So it's going to decrease the sympathetic tone in the heart. The heart is going to beat slower and with less force. Okay, that will decrease the blood pressure. What if you gave him epinephrine? Well, his blood pressure would go through the roof. It would probably be well into the 200s. Albuterol? Well, again, albuterol, not really the right delivery method. Usually that's an inhalation or an aerosol. And while it would open up his bronchioles and maybe have a little bit of a side effect of tachycardia, really that's not going to touch his blood pressure at all. It would probably still stay about the same. Lastly, what about phenylephrine? Well, phenylephrine, one of the uses of phenylephrine is actually as a pressor. So that would, again, increase his blood pressure by clamping down on the peripheral vasculature. And that would be the wrong choice. So if you chose D, metoprolol, awesome. Good job. Hey guys, thanks for watching this video. I really enjoyed making it, and I love interacting with students. So leave me a comment, let me know what you thought. Give me some ideas, something you want to talk about, or some topic that you might need help with. Give me a like, subscribe, and lastly, good luck in school.